If all goes well, this will be the last video for the semester for any class. So the two variations of positions we've talked about before that are specific to sinuses involve visualization of specific sinuses while maintaining a horizontal central ray. And this is the first one. So to review the PA axial, that is Caldwell method that we've talked about before, what we will do is place the patient's forehead and nose on the image receptor and angle the central ray 15 degrees caudally. In doing so, projects the petrous ridges into the lower third of the sinuses. Well, in this case, we don't want to do that. We want to maintain a horizontal central ray and angle the anatomy. So what we want to see is frontal sinuses above the frontal nasal sutures, or suture. We want to see the anterior ethmoid air cells, even though you can't make a diagnosis of them. It's a part of the evaluation. We want to see the sphenoid sinus seen through the nasal fossa, below or between the ethmoid sinuses, and we want to see the petrous ridges just where they were in the lower third of the orbits. So it's sort of a Caldwell. It's not really a Caldwell. Again, your Caldwell is PA projection with caudal angulation, but we're going to angle the head instead of angling the central ray. So there's a couple of different ways to accomplish that, and if you look on page 100 of your textbook, you'll see what it is. So in the first variation, what you're going to do is angle the vertical grid device 15 degrees with a top towards the central ray. Effectively, what that's going to do is if you put the patient's nose and forehead on the image receptor just like what you would for a Caldwell, that should be a 15-degree angulation caudally into the skull, even though the central ray is actually parallel. So is it an axial since the central ray is not angled? Well, it's still angled to the central ray or to the image receptor, so it still kind of satisfies the requirement. The other alternative is to just put the patient's nose on the image receptor, elevate the forehead away from the image receptor so that the orbitomeatal line forms a 15-degree angle to the central ray. So either one of those will accomplish the same thing, and that should put the petrous ridges into the lower third of the orbit so that we can see the frontal sinuses a little bit better. So both cases, it's a 15-degree tilt for the orbitomeatal line and its relationship to the central ray. So horizontal central ray, you don't want to use an angulation on central ray because we're looking for air fluid levels. Horizontal central ray, your collimation is going to be small, remembering that everything that you want to see is from the nasal cavity up. You don't need a full 10 by 12 image receptor. So open your collimated field to 1 inch beyond the skin, and it should exit in the same spot, that being the nasion. It's just that you've collimated more and you've used a tilt of the head rather than the tilt of the central ray. So evaluation is going to be really the same, except for you've got the collimation. So the structures shown are going to be a little bit different, but really the evaluation for rotation and things like that remain the same as what they were for the other Caldwell. Petrous ridges in the lower third of the orbits, and what you should see is this. So again, you've got the sphenoid sinus through the nose. Can't make a diagnosis of that. The ethmoid sinuses just medial to the eyes. Can't make a diagnosis of that either. But what we're looking for really is the frontal sinus, which is what we're seeing here. Frontal sinuses are really pretty thin, but they should stand out a little bit better than what we're seeing here. This patient appears to have something going on inside that frontal sinus. I don't know if they've got a headache or a sinus infection, if they presented with a headache or what exactly. So our waters is going to be the same waters we saw before, where we maintained a horizontal central ray with waters previously. So there's no real difference between the waters for the facial bones, or waters for the nasal bones, or waters for the petrous ridges, or I'm sorry, for the maxillary sinuses. Petrous ridges should still lie below the maxillary sinuses. It's the 37 waters. It's not the modified waters. Modified waters is 55 waters. We're looking at a 37 here, because, again, we want to put the petrous ridges below the maxillary sinuses. So hyperextend the neck until the OML forms a 37-degree angle from the image receptor. And everything else is pretty much the same. Collimation is going to be a little bit tighter. It's going to exit at the acanthion, just like the other waters. Really no difference except for your collimated field is going to be smaller at 8 by 10. Your evaluation criteria is going to be the same. The most important being this right here, making sure your petrous ridges are below the inferior floor of the maxillary sinuses. So increased collimation so that you can see these. And again, comparing the two sinuses, it looks like this patient's got a occluded right maxillary sinus. So the one variation, and really the only other new thing that we're going to add for sinuses, is an open mouth waters. So if you look at this, you see this dark area right in between the teeth. That's the upper incisors, lower incisors. And what you see right there is actually a portion of the sphenoid sinus. So in order to visualize that sphenoid sinus through the open mouth, what you would do is you would position your patient like a waters, but you would have the patient open their mouth. A couple of very important things that I didn't really point out before, but anytime you're doing sinuses and anytime you're putting the patient's face up against the image receptor, we did talk about this in class. You want to clean it off, and you want to clean it off in front of the patient. But the other thing with the open mouth waters is you don't want to position the patient for this projection and then have the patient open their mouth. Because in the 37 waters, you're going to put the chin up against the image receptor. And if you place the chin up against the image receptor and you have the orbital-meatal line at a 37-degree angulation, and then you have the patient open their mouth, what that's going to do is further hyperextend the neck, and they're going to be at a greater angulation, 37 degrees. So what you want to do is you want to have the patient open their mouth, and then you're going to move them into the image receptor, maintaining that 37-degree angulation. Where'd it go? 37-degree angulation between the OML and the image receptor. So what you see in the open mouth waters is once the patient gets their mouth open, and it kind of looks like what they did was they push, actually what this truly is what they call a Peary method. And a Peary method utilized a caudal angulation along with the open mouth. So what that did was it projected the petrous ridges even lower. But if you put the patient's nose or their chin up against the image receptor and then have them open their mouth after you place it, this is what you're going to get with the petrous ridges not even being located. I can't even find them on here. So open the patient's mouth before you have the patient put their face up against the image receptor. But what we're trying to see is the sphenoid sinus through the open mouth, just like that. All right, so SMV, there's nothing new for the SMV. It's the same thing that we've looked at before. The IOML needs to be parallel to the image receptor. You do need to go back into the bucky for this one, as opposed to on the facial bones. You didn't need the bucky since we were just shooting through the zygomatic arches, but now we're shooting really through the entire head, because what we're looking for again is the sphenoid sinus. So this is just another view for the sphenoid sinus. So extend the neck until you put the IOML parallel to the image receptor. And I'm going to kind of go off script here and say that if the patient cannot extend this far, as you're going to have to do this upright in order to see sinuses. But if a patient cannot extend that far, I'm going to say go ahead and angle your central ray perpendicular to the IOML. And the reason I say that is because if we get down here to the images, this is the sphenoid sinus. Nope, this is sphenoid sinus right here. So if the patient's chin is tucked, what you're going to do is you're going to take the sphenoid sinus and you're going to tuck it into all this mess back here. So it's probably a little more important from a practical standpoint to make sure that you can visualize the sphenoid sinus, even if you've got a little bit of a blur to the air fluid levels, than to not see the sphenoid sinus at all. But according to positioning in a textbook, you have to have a horizontal central ray in order to see air fluid levels. But I'm telling you from a practical standpoint in clinicals, get your central ray perpendicular to the IOML. And that's really it. So the sinuses test will be 1 week prior to finals week. So let's see. Finals week, the final day of the semester is May 6th. So our final exam should be on April 27th. So our sinuses test will be April 20th. And I hope the recordings have helped it to not be quite so complicated this semester. And I hope that we can get back into class first thing in the summer.